Hello, Dr. Simone, can you hear us?
Yes, perfectly.
Yes. Yeah, you can get started in exactly a minute. Could you start your screen sharing, please?
Yes.
First of all, sir, I'd like to really apologize for the technical issues that we had, and we managed to sort it out. I'd like to invite Professor Simone. Professor Simone is a professor from the University of Genoa, Italy. He has also trained in operative gynec endoscopy from Clermont-Ferrand, France, and from the University of Strasbourg, France. He's also done his PhD. He's published more than 250 articles which are in peer-reviewed journals. His main clinical research areas of interest are endometriosis, uterine myomas, gynec surgeries, and gynec oncology. He's also right now the vice chair of the Fibroids Special Interest Group from the ASRM. Welcome, Professor Simone, and can we please ask you to, we have Dr. Niranjan here.
Thank you, Simone. Sorry for the delay. This is Niranjan Chavan from Mumbai. We have been in touch with during the COVID pandemic and also on the editorial board of the Journal of European Journal of Gynae Oncology. Welcome. Everyone is looking at you and eager to hear from you. Thank you.
Thank you for your invitation. It is really a pleasure to participate. Why we should use selective progesterone receptor modulators in the treatment of uterine fibroid? Well, several variables are involved in the pathogenesis of uterine fibroid. However, estrogen and progesterone really do have a pivotal role. And in this perspective, we must consider that estradiol promote tissue sensitivity to progesterone and increase the availability of progesterone receptor within the fibroid. Progesterone is required for the development and the proliferation of fibroid cells. And therefore, these two hormones are deeply involved in the pathogenesis of fibroid. Here you can see the details. Progesterone acts on several molecules, such as EGF and TGF-beta3, which increase because of the progesterone stimulation. And this leads to myoma growth and formation. When we deal with uterine fibroid, we have several hormonal therapies that we may consider. And in this perspective, selective progesterone receptor modulator were really very interesting. The main advantage of this molecule is that they may have an agonistic or an antagonistic effect depending on the tissue, and because of this reason, they were really suitable for treating uterine fibroid. In Europe and here in Italy, we have an extensive experience with the use of Ulipristal acetate. Ulipristal acetate is a selective receptor modulator that is commonly used for emergency contraception as a single dose of 30 milligrams. However, it has also been approved in Europe in 2012 for the treatment of uterine fibroid at the daily dose of 5 milligrams for 3 months. This is a treatment that is approved for managing fibroid with moderate to severe symptoms, obviously in women of reproductive age. Ulipristal acetate has several activities on uterine fibroid, including inhibition of the mitosis, decrease of the angiogenesis, increased degradation of the collagen, and decreased expression and function of activin A. And the efficacy of Ulipristal acetate was evaluated in the Pearl and Venus trial. I'm sure that you are all aware of this trial. The Pearl 1 compared Ulipristal acetate with placebo, demonstrating that this drug effectively controls excessive bleeding caused by uterine fibroid. And the Pearl 2 compared Ulipristal acetate with leuprolide acetate, a GnRH analog, demonstrating that Ulipristal acetate is not inferior to the GnRH analog. Other two trials, the Pearl 3 and the Pearl 4, evaluated repeated cycles of treatment with Ulipristal acetate, which were interrupted by a short period of treatment with NITA or placebo. And these two trials confirm that the long-term treatment with UPA is effective in decreasing the bleeding caused by fibroid and in improving quality of life of patients. Similar findings were reported by the Venus 1 and Venus 2 trial, confirming that UPA is effective in improving symptoms caused by fibroid, in improving quality of life and the degree of bleeding. And more recently, the same findings were confirmed in a Japanese population in a phase 3 randomized controlled trial, which compared patients treated with Ulipristal acetate with those treated with leuprolide acetate. The percentage of patients who reached amenorrhea was similar in the two study groups, 87% with UPA and 81.8% with leuprolide acetate. However, interestingly, the mean time required to achieve the amenorrhea was significantly shorter with the Ulipristal acetate, providing an advantage for the patient. However, there are some safety issues that must be considered. First of all, when we started the use of Ulipristal acetate, we noticed that there were strange changes in the endometrium. In particular, as you can see here, there are some cystic glands within the endometrium and increased thickness of the endometrium. Because of this, we were worried that these changes of the endometrium caused increased risk of endometrial cancer or at least endometrial hyperplasia. This is the typical hysteroscopic view that you may see in a patient treated with Ulipristal acetate. However, these changes are only morphological changes of the endometrium, which are caused by the molecule. They are reversible and they disappear after discontinuing the treatment. And there is no evidence that this increased the risk of developing endometrial cancer. Then we have another more serious problem, which is the hepatotoxicity of the drug. There was no evidence of liver injury during the clinical development program of the molecule. However, on 22 September 2017, the French Medicine Agency reported a case of fulminant hepatitis that led to hepatic transplantation. Because of this, the European Medicine Agency started an Article 20 procedure in order to review whether the molecule was associated with a risk of liver injury. And during this procedure, there was another case of fulminant liver injury. The patient required transplantation and finally died because of the complication of the transplantation. The report of the European Medicine Agency could detect 8 cases of severe liver injury with a possible contributing role of Ulipristal acetate, and several other cases of hepatic disorders that were not so severe were encountered. Because of this, Ulipristal acetate was allowed only for long-term intermittent treatment of women that were not eligible for surgery. In addition, the European agency requested that liver function tests were performed before starting the treatment, monthly during the treatment, and 4 weeks after the treatment. However, despite these changes in the management of the drug, in December 2019, there was another severe case of drug-induced liver injury. And this was not prevented by the safety precaution that I just described. And because of this, the European Medicine Agency started an Article 31 pharmacovigilance referral of directed procedure. What happens? There are some cases that are reported in the literature. The patient typically has an increase in the transaminases. She may develop nausea, fatigue, abdominal pain, and then this patient undergo liver biopsy, the hepatitis is demonstrated, and they undergo liver transplant. And this is another case that was reported with a very similar course. Therefore, it is quite evident that the Ulipristal acetate may cause a liver injury. However, liver injury occurs with several drugs that we routinely use in our clinical practice. Here you can see the number of drug-induced liver injuries that occur for 100,000 patients using a particular drug. And you can see that at the end of the day, Ulipristal acetate is not more dangerous than several other drugs that we use in our common clinical practice. In particular, the risk of a drug-induced liver injury is approximately 11 in 100,000, and the risk of liver transplantation is approximately 0.6 for 100,000. All surgical treatment or medical treatment have risk, and if we do not prescribe an hormonal therapy, we must decide to make surgery. I do not have the time to go into the detail of the risk of surgery. However, this is a simple report performed in the UK that demonstrated that the risk of death from a laparoscopic hysterectomy performed because of fibroid in the US is 12 out of 100,000. And when we consider an abdominal hysterectomy, the risk is 32 out of 100,000. The numbers are not so different, but obviously Ulipristal acetate must be prescribed by surgeon who should administer to a patient a hormonal treatment that may cause hepatotoxicity. And probably this was the end of the diffuse use of this drug, at least in my country and in Europe. Which are the mechanisms of hepatotoxicity? Well, they are not well known. We have to admit that several molecules of the same family have been removed from the market because of hepatotoxicity. Transaminase elevation have been reported in the first 3 months of treatment. And finally, Ulipristal acetate and its metabolite may accumulate in the dose-dependent manner, and this may cause the hepatotoxicity, also depending from a large inter-individual pharmacokinetic variability. When we may consider Ulipristal acetate? Well, because of before surgery, we were among the first to report the experience of the use of Ulipristal acetate for very complex laparoscopic hysterectomy. And we showed that the Ulipristal acetate was efficacious in improving hemoglobin preoperative levels, in decreasing the largest diameter and the volume of the myoma, and more importantly, in decreasing the intraoperative blood loss and the risk of transfusion. Furthermore, because of the lower volume of the fibroid at the time of surgery, we had a shorter operative time and quicker suturing time. These findings were not confirmed by other authors. However, the population was difficult because other authors simply included patients undergoing laparoscopic myomectomy, while our cases were very complex procedure. And one of the major criticisms that Ulipristal acetate may receive before laparoscopic myomectomy is that the cleavage may become more difficult. I don't have the time to show you long video. However, we have to admit that in some cases, the myoma is really adherent to the myometrium, and the dissection may become quite difficult. However, it is feasible. This is a recent case that was performed by one of my fellows. You can see that the myoma actually in some point is strictly adherent. However, in most of other cases, the myomectomy can be easily performed. So the difficulty in obtaining the excision of the myoma occurs only in a limited percentage of the patient. The real competitor for Ulipristal acetate before laparoscopic myomectomy is the GnRH analog. This was a systematic review that demonstrated that both treatment may improve surgery and in particular may decrease the intraoperative blood loss. But most recently, a randomized controlled trial had the objective to compare pre-treatment with Ulipristal acetate of GnRH analogs before laparoscopic myomectomy. This trial was ended preterm because the non-inferiority of Ulipristal acetate could not be demonstrated. Patients treated with Ulipristal acetate had higher intraoperative blood loss than those receiving a GnRH analog. And furthermore, the suturing time was higher in patients treated with Ulipristal acetate than in those receiving GnRH analog. Because of this, the study was ended preterm. And in a longer follow-up performed starting at 6 weeks from surgery, it was not possible to observe differences in the hemoglobin level of patients pretreated with the two types of therapies. And furthermore, no significant difference were observed in the long-term follow-up concerning hemoglobin level and quality of life. Ulipristal acetate may be considered before hysteroscopic myomectomy. We were among the first to report the use of UPA before hysteroscopic myomectomy. We demonstrated that obviously Ulipristal acetate decreased the volume of the fibroid, also of the submucosal fibroid. However, the decrease is lower than that they observed with a GnRH analog, triptorelin, or with letrozole. And in the first study, the sample size was very small, therefore it was difficult to understand the impact of Ulipristal acetate on surgical variables. However, we received several criticisms because UPA may increase the thickness of the endometrium and therefore theoretically make the hysteroscopic myomectomy more difficult. Actually, I do not think that this is really relevant. If you want to perform extensive hysteroscopic myomectomy, complex hysteroscopic myomectomy, you can't have the problem of endometrium. When it is thick, you may remove it and you can safely perform your hysteroscopy without big problems. And this was the objective of this study that we published in the Journal of Minimally Invasive. These were very complex cases of hysteroscopic myomectomy, and we demonstrated that the pre-treatment with UPA caused a higher rate of complex, complete resection compared with no preoperative treatment. And also, I am used to perform outpatient hysteroscopic myomectomy by using the VersaPoint. This is the technique that I commonly use. And I have to admit that the use of Ulipristal acetate before outpatient hysteroscopic myomectomy can make the procedure much easier. This was also reported in the publication that you can see in the top right. Ulipristal acetate may also be compared with surgery. We do not have currently real data. The protocol of a multi-center randomized non-inferiority trial was published in the European Journal of Obstetrics, Gynecology and Reproductive Biology, but we still do not have the result of this trial. Finally, UPA may be used before conception, before spontaneous conception, and before IVF. And I fully agree with Professor Donnet that UPA may cause a migration effect of the fibroid, which have a submucosal component. In patients wishing to conceive, which have a decreased ovarian reserve, which are approximately 40, shrinking the myoma may improve the implantation of the embryo. Limited data, however, are available, published If any one of you is participating to the next RSRM, this is a roundtable that I will have, and I will present my experience with the use of UPA before IVF. In conclusion, safety is a major concern for the treatment of fibroid with Ulipristal acetate. The patient must be counseled about the risk of hepatotoxicity. They must be informed that they need to perform liver testing before starting the treatment and monthly during the treatment. They must also be educated regarding the potential risk of liver injuries during the therapy, and therefore they must be aware of the symptom caused by liver injury. Obviously, we must be confident that the patient will perform the exam. In the case we feel that the patient will not adhere to the protocol, it is better to avoid to use Ulipristal acetate. Before prescribing UPA, we must evaluate the history of the patient. In particularly, we must understand if there is any underlying liver disease which may increase the risk of the patient. And as I said, we must periodically prescribe the transaminase assessment. Concerning the indication, the use of UPA should be not recommended before laparoscopic myomectomy. Probably GnRH analogs are superior to UPA, and therefore they must be preferred if a preoperative treatment is required. In contrast, UPA may facilitate complex hysteroscopic myomectomy, and therefore it may be considered before this type of procedure. Obviously, UPA may be considered when patients do not respond to any type of treatment, surgery is contraindicated, uterine artery embolization didn't work, then in this patient we may consider to use Ulipristal acetate. And finally, a very relevant role, in my opinion, is the use of UPA in patients wishing to conceive, which are over 40, which have a poor ovarian reserve, where surgery or other non-hormonal treatment may impair their fertility. Thank you for your attention.
Thank you so much, sir.
Thank you. Thank you so much, Professor Simon. I think that was a nice comprehensive talk on UPA, and probably would be a little more confidence building for all of us to use UPA because of the liver toxicity and all that we're scared of. So, sir, I would just like to ask you one question, that how long in your experience have you used a UPA for? Like a 3 months or a 6 months? Because one of your papers you said it was used even for a 2-year period.
Well, I have to admit that before the issue of the liver injury, I have data of periodical use of 3-month treatment, then 1 menstruation, spontaneous menstruation, and then other 3-month treatment, and spontaneous menstruation, and so on for over 1 year. So I was really used to use this molecule for a long time. Some patients were treated for approximately 18, 20 months without any problems. And I have to admit that they were very, very satisfied.
That's nice. And then once you stop it, how long does it take for the fibroids to grow back again?
It is it is quite fast, they grow back. It depends also from the shrinking that you had, obviously, and the length of preoperative treatment. But between 3 and 6 months, you go back to the baseline volume.
Okay. I think, thank you so much, Professor. Thank you so much for joining us today. And
it was a pleasure. Thank you for inviting me. Grazie.
Thank you so much. With this, we conclude this session.